So either Kenza or Brenda started recording. Thank you. So for those who haven't attended before and don't know me, I am Rhea Markowitz, and I'm from the Georgia Cancer Center, the teledermatology serving Georgia hub team for this TeleECHO session. Dr. Doug Patton and I will be serving as co-facilitators for the session today. So let's see, the next slide will show you our, no, go back to the website. Want to remind you all about our wonderful teledermatology serving Georgia website. There is a lot of information on this website. There's a page for healthcare providers that have training videos on them, and there are and those training videos, if you enter them correctly, you can get CME credit for watching those, and it's a wealth of information there, things that we went over when we first started, and you could refresh your memory on characteristics of the different types of skin cancers or just dermatology information and so on. And then there's a link to almost all of the 35 TeleECHO sessions that we've had in the past, and you can go and look at those if you are interested. So let's see. So I want to welcome everyone here. We've got primary care providers from the East Georgia healthcare centers who are participating in the clinical arm of the teledermatology project. And we may have PCPs from other healthcare centers throughout Georgia. We have residents and faculty from MCG's Family Medicine Department who are also participating in this phase 2 of the clinical arm of the project. We have our resident dermatologists here. We've got Dr. Kendall Buchanan and Dr. Harold Rabinovitz and Dr. Loretta Davis, who is maybe in her office or was walking from clinic to her office, but they're all here. There are some MCG medical students, and then we have members of the Georgia Cancer Center TeleECHO hub team, Kenza Mamouni and Brenda Santiano, and they're doing all the technology and running the show here, and we couldn't do this without them. I am eternally grateful for all of their help. And we may have participants on board from that have attended in past years. And if anyone is new attending, we welcome you. And as people were being admitted, I was noticing that there were some names that I hadn't recognized. So so I do believe we have some newcomers, and we welcome you to our session. So just going over the agenda for today, we're doing our introduction. Our didactic presentation will be by Dr. Sally Young, a PGY3 resident in the Department of Dermatology. And Dr. Young has done at least one other presentation for us in the past year or two. And then our student presentation is, the case presentation is by Maya Akbik, who's a third-year medical student, and she is from the Athens campus. So we welcome her to our TeleECHO session. And now I will introduce my co-facilitator, Dr. Doug Patton. Dr. Patton's the Dean of the Southwest Georgia Regional Campus for MCG, and he spent most of his career as a rural physician, as many of you in the audience are. So at this point, I will turn it over to Doug. Take it away.
Thank you, Rhea, and it's good to have everyone here today. We hope that the groundhog's forecasting that we have 6 more weeks of winter may not be entirely accurate. Well, we can hope for that. But we're going to start with our normal reminders about what Project ECHO is, the extension for community healthcare outcomes, and the motto is sort of moving knowledge instead of people. If you'll go to the next one, there we go. The TeleDerm sessions are designed to improve through use of telemedicine and teleeducation, the ability for providers outside of the academic medical center sphere to be able to improve the quality of care and the scope of care that they're able to provide in their own setting, helping to face some of the disparities in healthcare access that we face in many areas of the country, but are particularly acute here in Georgia. Next slide, please. So these are educational quality improvement purposes. That's why these sessions are recorded. If you're still online, that means you've implied your consent to be recorded. And also as a reminder, because these are not secure conversations, these are not consultative. We ask that you please don't mention any PHI in the discussions. Please just anonymize your comments if you don't mind. There will be instructions about continuing education credits, how you claim those, that will be reviewed again at the end of the session. But if you go back to the website, as Dr. Markowitz pointed out earlier, there's plenty of opportunity for you to sample the continuing education offerings as well as to gain credit through the website. You can always email questions or technical issues to teledermatology@augusta.edu. You can always put questions in the chat as well. So next slide, please. So we do collect data. That's part of what we use to help do continuous quality improvement, not only from registration information, but also chat information, questions and answers, things like that are used to help us shape the programs that we develop in the months going forward. So next slide, there we go. Just the general Zoom reminders, to mute when you're not speaking, unmute when you do. Questions can be typed into the chat at any given time. You can raise your hand electronically and we will be monitoring for that. And when the time is appropriate, we'll recognize people. Then you can open your mic and speak up. If it's time sensitive and you just can't stand it, then go ahead and open your mic and introduce yourself. We'll try and squeeze your questions in if we need to under those things. Please use your cameras to the extent that you can, as long as your bandwidth will allow you to, so that we can see as many smiling faces as we can. Again, you can chat or put the questions in the chat or technical issues in the chat, or you can email Kenza at kmamuni@augusta.edu. Next slide, please. So it's my privilege at this point to introduce Dr. Sally Young, who's a third-year dermatology resident at the Medical College of Georgia, and she has a presentation to share with us on non-scarring alopecia. Dr. Young, thank you for joining us today. We look forward to hearing from you.
Thank you for the introduction. Let me just share my screen real quickly. All right, so hi everyone. Again, I'm Sally Young. I am a PGY3 dermatology resident, and today I'm going to be talking about non-scarring alopecia. We thought that talking about hair loss in general would be a good idea because hair loss can be somewhat overwhelming and difficult to manage. But if you know the kind of different clinical presentations and know what to look for, it can be pretty manageable. At least in dermatology, we tend to split hair loss between scarring and non-scarring etiologies. So today I'll be going over the non-scarring ones, and I hope to come back sometime in the future and maybe talk about the scarring ones as well. So on with my presentation, these are just my learning objectives. But we'll basically start with the beginning of any medical kind of visit with a history of present illness. When you approach hair loss, I think it's really important to get a good history and ask some good questions, because these questions, along with their clinical patterns, will ultimately help you decide what type of hair loss it is. And it can even help you decide between non-scarring and scarring. I try to format this presentation to include these important patient history elements with each type of hair loss, and this slide may make better sense after we go through the entire presentation. But here are some of the things that we like to ask and things that we consider when it comes to hair loss. First, I think it's really important to determine what patients are talking about when they say hair loss. Patients often come in saying, hey, I just have hair loss, but they could mean, diffuse hair shedding, reduction of hair density, or hair breakage. And all of that just means hair loss to patients. So I think it's really important to make that distinction. Second, it's important to ask if patients have any scalp symptoms such as scaling, pruritus, or burning. And this can really clue you into whether this is a non-scarring or scarring process. Typically with non-scarring alopecia, patients may have some mild scalp symptoms, but if they do have kind of intense scaling, pruritus, or burning, that's more characteristic of a scarring alopecia. Next, we also want to know how long the hair loss has been occurring, when it started, if it affects other hair-bearing areas, and whether it is a persistent or waxing and waning course. And then another big part of alopecia are these next 3 bullets where you want to take into account some of their social and medical history. Social history, including nutritional history, hair management practices, and then medical history as well, because all of this can really contribute to hair loss. And then lastly, I think it's important to know if there is a family history, as some of the non-scarring alopecias do have a genetic component, such as androgenetic alopecia and alopecia areata to a certain degree. This is a great photo or table from JAD and the Cleveland Clinic, kind of going over all of the different non-scarring alopecias and showing a diagram of all of the different patterns. And this is really important because you can see that all of these non-scarring alopecias do have a distinct pattern, and this can help you with the diagnosis. So today I'll be going all of these, including traction alopecia, androgenetic hair loss, telogen effluvium, alopecia areata, and tinea capitis. And another one along with this differential includes trichotillomania, which we will go over today as well. So we're going to start with traction alopecia, and here you can see that it has this kind of characteristic look down here. And with traction alopecia, this comes from repetitive and prolonged tension on the scalp hairs, and this tension can really come from anything such as braids, ponytails, hair extension, or hats. And this will lead to accentuated hair loss in areas with the greatest tension. And it's typically on the frontotemporal scalp like this photo and here as well. But here you can see that it really can be anywhere with tension, like in between the braids, and it can be pretty progressive. Another characteristic sign of traction alopecia are these 2 photos down here, which are called fringe sign. And fringe sign is when scalp hairs in the frontotemporal area, there is kind of this retained hair and then kind of an area of alopecia and then normal hair. And that's what we call fringe sign. Late stage disease with traction alopecia can actually lead to a scarring alopecia from just permanent damage. So it's really important to recognize this early on and prevent it when you can. So for treatment of traction alopecia, first you want to switch to a looser hairstyle with less tension. You can always consider topical or low-dose oral minoxidil and the topical or intralesional corticosteroids whenever there is a significant amount of inflammation. Moving on to androgenetic alopecia, or male pattern or female pattern hair loss. And this is caused by genetic and hormonal factors that lead to an increased DHT, which leads to local androgen-driven process of the scalp, ultimately leading to the loss of your thick terminal hairs and development of thin vellus hairs. We often call this miniaturization of hairs, and you'll see that patients will just have progressive thinning of their hair in their scalps. In men, DHT levels can fluctuate and increase with age, which is why we often see this kind of hair loss in the elderly. And then in females, you can have it with increase in age, as there is increased DHT with hormonal imbalances like menopause, but you can also have increased DHT levels with other diseases like PCOS or hyperandrogenism in general. For androgenetic alopecia, it's pretty unique in that it presents differently among men versus women, or males and females, and we'll go over those characteristic patterns today. Starting with male pattern alopecia, in men, it typically affects the frontotemporal line, as you can see here. But it can also affect vertex of the scalp over here and here. And this is a great scale. It's called the Norwood-Hamilton scale. And it just kind of shows you that it can be pretty mild, but also severe and affect kind of the entire vertex of the scalp. Trichoscopy or dermoscopy of the scalp can be helpful in some of these non-scarring alopecias, and we'll go over some of the characteristics today. But in androgenetic alopecia, in both men and women, you'll be able to appreciate the miniaturized thin vellus hairs here, along with the thick kind of healthy or terminal hairs that you see here. And you can see that it can be kind of random and throughout. For male pattern alopecia, we typically start with topical or low dose minoxidil, and you can consider oral finasteride or dutasteride, which are 5-alpha reductase inhibitors. And these medications, minoxidil and the 5-alpha reductase inhibitors, can sometimes be used together. Female pattern hair loss is a little different in that it doesn't really affect the frontotemporal or vertex, but it does affect kind of the midline or where the part is. And it's described to be a Christmas tree pattern. As you can see that as it gets more severe, that it does take on this kind of Christmas tree pattern that we see here. And again, it can range from mild to pretty severe. Going back to the relationship of increased DHT and hyperandrogenism, we do recommend considering screening labs for hyperandrogenism with serum DHEA, total and free testosterone, especially if women are having other symptoms than hair loss. Treatment is pretty similar as to male pattern hair loss. You can use topical or oral minoxidil, sometimes oral finasteride and oral dutasteride, and then spironolactone, which is an aldosterone antagonist. We often reach for minoxidil and spironolactone, especially spironolactone if the patients have other symptoms of PCOS, such as hirsutism and acne, and these medications can be used together. Moving on to telogen effluvium, you can see that with telogen effluvium, you just have these kind of spotty areas of hair loss, kind of diffusely on the scalp. Telogen effluvium is caused by internal or external factors that interfere with the normal hair cycle. So in this, you have an increase in your telogen phase hairs, which leads to diffuse hair shedding. The telogen phase typically lasts for 3 months, which is why we see hair shedding typically around 3 months after the inciting cause. Because of this, you just typically have diffuse thinning and lots of terminal hairs throughout the scalp. Sometimes I think it can be hard to assess the degree of hair shedding because normal hair shedding is the thing, and patients do shed hair in various amounts depending on the patient's scalp, quality of hair, things like that. So that's when the hair pull test comes in handy, and these two bottom photos depict what the hair test is. And with the hair test, what you do is you bundle a section of the hair, grabbing about 50 to 60 hairs, firmly pulling on the bundle with slow traction. The point isn't to really rip out the hairs, but more to gently pull. And if more than 10% of the hair is removed, then the hair pull test is considered positive. So with a bundle of 50 to 60 hairs, if you pull about 5 to 6 hairs, that would be considered positive. And if less than 10% falls out, then that is considered normal shedding. So that's a useful tool that you can do in clinic and easy to do. And then for trichoscopy, so telogen effluvium is usually diagnosed on a clinical presentation, but you can use trichoscopy, and you'll see here that patients will have some small hairs that are growing. And I think that's reassuring to patients as you can tell them that, this isn't a permanent process and the hair will grow back. As I mentioned, telogen effluvium is caused by internal or external factors, so it's really important to determine what that trigger is. And there are a lot of different triggers, but some common ones include pregnancy, high fever or illness, nutritional deficiencies like iron deficiency, systemic disease like thyroid or autoimmune disease, emotional stress, surgery, inflammatory scalp disorders, and medications. This is a great table that kind of goes over some of the triggers of telogen effluvium that we see, but I wanted to focus on the bottom half of the table because it does show some of the medications. And you can see that it's a pretty long list, but there are some common medications on there, such as anticoagulants, antithyroid, beta blocker, NSAIDs, and allopurinol. And it's important to know because a lot of our patients are on these medications, and it can be worth counseling patients on this and setting expectations for possible hair loss. After a history and physical exam, if the triggering factor is still unclear, you can consider a lab workup. Typically, what we'll do in clinic, we'll get a thyroid, serum ferritin levels for iron deficiency, CBC, and CMP, and we will sometimes do a vitamin D. Studies have shown that patients with telogen effluvium tend to have lower serum levels of vitamin D, and there have been some studies that show hair regrowth with vitamin D therapy. And then for treatment, most important is avoiding the trigger. Obviously, if a patient has had a recent illness or surgery or pregnancy, it can't be avoided, but kind of setting expectations that the hair will grow back is important, and letting patients know that, if they go through something like this again, it may happen again. Discontinuing any medications or changing any medications that may be causing the hair loss can make a big difference. And then treating the underlying cause with iron supplements or thyroid medication can help as well. And then lastly, we do recommend topical or oral minoxidil. Moving on to alopecia areata. So alopecia areata is very complex in that it is caused by a combination of immune, genetic, and environmental factors. It typically presents with this kind of oval, round patch of non-scarring hair loss. And here you can even see that there is some hair regrowth throughout the alopecia patch. But there are other characteristic patterns of alopecia areata that I think is really important to be able to identify. And the first one is called ophiasis, and that's shown in the middle photo. And this presents with band-like pattern of hair loss along the periphery of the temporal and occipital scalp. So it's kind of under here. And then the next is also called inverse ophiasis or Sisypho, which is where the hair loss bears the temporal and occipital area and is more on the vertex here. Alopecia can be pretty severe and affect all of the scalp, which would be called alopecia totalis. And then when it starts to affect the body hair as well, it's called alopecia universalis. So treatment includes topical or intralesional steroids, which we do often. You can also try topical calcineurin inhibitors to help with the inflammation, topical or oral minoxidil, and we do initiate some patients on JAK inhibitors, and it's been shown to be really helpful in some cases. And then lastly, we're going to talk a little bit about tinea capitis. Tinea capitis is a little different from the rest of these, as you'll see with the clinical presentation, in that it's often associated with scale. So tinea capitis is due to a dermatophyte infection, and it more commonly affects children. It typically presents with scale and inflammation with alopecic patches, such as the first photo, but here you can see that sometimes the scale is absent. It can be confined to one little oval patch, but it can be pretty diffuse and cause a lot of the hair to go to be lost. And then sometimes when the inflammation is so severe, it can lead to a carry-on, which is shown here, and that's where the scalp becomes really boggy with purulence and abscess formation. And all of this, if left untreated and becomes severe, can actually lead to a scarring alopecia. Of note, a lot of these patients will also have cervical and postauricular lymphadenopathy as well, just from the highly inflammatory process that's going on. On trichoscopy, you may be able to see these kind of comma and corkscrew hairs with your dermatoscope. So for treatment, because this is an infection of the hair follicles, you do have to do a systemic therapy because the topical agents won't penetrate the hair follicles. Terbinafine is considered equally effective and safe compared to griseofulvin, and studies suggest that it may be more superior for trichophyton species, and griseofulvin may be more superior for microsporums infections. In the US, tinea capitis is usually caused by trichophyton, so in the clinic for us, we find ourselves grabbing oral terbinafine more often than griseofulvin. So this was just kind of a basic overview, and I do think this chart is really helpful to just kind of go back and try and help you determine what kind of non-scarring alopecia is going on. And I think the great thing about being able to identify non-scarring alopecias is that we can often spare patients a biopsy of the scalp if we're able to just use a clinical history and presentation to come with a diagnosis. But I do really think that it's hard to sometimes differentiate between non-scarring and scarring alopecia. The top row here should look really familiar because those are all of the ones that we went through today. And the bottom ones are the scarring alopecias, but here you can see that there are some overlaps between the clinical presentation, and sometimes differentiating between non-scarring and scarring can be really difficult. This is where dermoscopy or trichoscopy can be really helpful. Dr. Buchanan gave a wonderful lecture on the use of UV-induced fluorescent dermoscopy at a conference, and I've definitely used this many times, especially for the scalp. So if you do have access to a UV-induced fluorescent dermatoscope, you may find this next tip to be very helpful in helping you differentiate between non-scarring and scarring. So in non-scarring alopecias, the UV fluorescent trichoscopy will show these pink, red, or green fluorescence. With a regular dermatoscope like here, you can see that it can be kind of difficult to tell whether this is a scarring or non-scarring process. But with the fluorescence, you can see these pink, red, or green little fluorescent lights that pop up. And the science behind it is that the pink red fluorescence is attributed to coproporphyrin 3 production, which is produced by C. acne. And C. acne only persists in viable hair follicles with preserved sebaceous glands. So if you see this, this means that there is a viable hair follicle there along with the sebaceous glands. Similarly, the green fluorescence is linked to malassezia, which is also an indicator of intact hair follicles. And compared to these photos here with the scarring process, you can see that here there really is no fluorescence, indicating that there is damage to the hair follicles, which I think would be a good indicator. And if there's any question about whether this is a non-scarring or scarring process, dermatology is always here, and we can always do a scalp biopsy to help determine the cause of the hair loss. And then lastly, I just wanted to do like a little PSA or bring awareness to minoxidil, because as you can see from all of the different non-scarring alopecias, the one medication that has been on all of them, except for tinea capitis, is minoxidil. And we recommend minoxidil to a lot of our patients with both non-scarring and scarring alopecias. So minoxidil is a vasodilator, and they also think that it may have some anti-inflammatory effect on it, which helps with hair growth. And it comes in a topical oral form, and I'll talk about those shortly. But with minoxidil, I think some things to counsel patients on is that first, you may experience some transient hair shedding with both the topical and oral medication. And this is normal, but just, reassuring them that that is to be expected and that they will have hair growth once they get over the transient hair shedding. And another thing is hypertrichosis. With the topical forms, anywhere that you get the medication on, like your cheeks or your eyebrows, you may have some hair growth there. And some patients may find that to be unappealing. And with the oral medications, you kind of grow hair everywhere. So that's something to counsel your patients on, just so that they are expecting it. Now, with the topical form, we recommend 5% solution or foam twice daily. With minoxidil or Rogaine, which is a brand name, there are 2% formulations, and those are typically targeted or marketed towards women or females. But the 5% is safe for everyone to use, and it works better, so we recommend the 5%. It comes in different vehicles, such as solution or foam. And I think it's really important to find and to let patients know about this, because some patients are particular about what goes in their hair, especially if it's going to stay in their hair all day. So some people prefer the foam because it has kind of like a mousse-like consistency, while others like the solution, but just letting patients know that it's out there. We recommend patients to buy these in packs. It's pretty affordable. Amazon, Costco, Sam's Club, Walmart, they all have this. And I did a little bit of digging, and at Costco, a pack for 6 is $18. It's marketed as like 6 months worth of medication, but we have found that it usually lasts patients about 3 to 6 months. And then for oral minoxidil, the dose can range from 0.625 to 5 milligrams daily. And I thought this was a great chart to kind of help you guide or help us with the dosing. For women, we typically start with 1.25 milligrams. They do come in 2.5 milligram tablets, so we just counsel our patients to cut these in half. And then for men, you can start with 2.5 milligrams and then go up to 5 milligrams daily. Some of the common side effects are leg swelling and dizziness, and there is a warning about minoxidil with cardiac complications. So these cardiac complications come from studies where high doses of minoxidil were used, and a lot of studies in dermatology have found these complications to be actually pretty rare with the low doses that we use in our patients for hair growth. And then contraindications, kind of going back to those cardiac complications, includes history of pericardial effusion, tamponade, pericarditis, CHF, pulmonary hypertension. In general, I think it's a good idea to reach out to the patient's cardiologist if you have any question about starting minoxidil. And then pheochromocytoma, pregnancy, and breastfeeding is also a contraindication. So that is the end of my presentation. I hope that, non-scarring alopecia is a lot easier for y'all to kind of recognize and manage, because I do think it can be a pretty rewarding disease or side thing to treat, and a lot of patients will thank you for it. But that's the end of my presentation.
Thank you, Dr. Young. That was very helpful. It's very comprehensive. I don't see any questions in the chat just yet. Glad to answer that one. Let's see. Brenda had a comment. There's a trend toward using topical tretinoin and retinoids in combination with topical minoxidil. Is this correct? Do you have an opinion on that?
I actually didn't know that there's been a trend. We don't typically recommend the combination use, and I don't know if like Dr. Buchanan or Dr. Davis could comment on that, but whenever I recommend it, I just recommend topical minoxidil.
Yes, I can comment. I mean, people think maybe it's absorbed a little bit better. I don't think it's really necessary. I think it's just a matter of using the minoxidil. Minoxidil used to be prescription topically. So I always tell my patients, because a lot of people think, oh, it's just over the counter. They don't want to pay for it maybe too, but they think because it's over the counter, it doesn't work. But just know that it used to be prescription. So there's a lot of evidence that topical minoxidil does work. And you just got to use it. So, and the only time you have to use it indefinitely, I did see that, is if it's inherited hair thinning. So if you use it to kind of jumpstart alopecia areata or tilia fluvium, then you don't need to necessarily use it all the time. But if you do have inherited hair thinning, you do, and it does work. It's just a matter of using it. So usually people start with the topical and then they use the oral if people just don't like the topical or won't use it. And just know that if you inherit hair thinning from a parent, it usually starts about puberty. And so you have to lose 1 out of every 2 hairs before you realize your hair is getting thin. So with strong family histories, the sooner you start it, the better it's going to work and hold on to your hair. So just a couple little side points about minoxidil.
Does that increase or is it unrelated completely to the likelihood that you could be related to the royals in England if you?
But yeah, inheritance is interesting, because a lot of people think they're going to have their dad's hair and they get their maternal grandfather's head, of hair thinning. So,
So this was about non-scarring. Just a quick question. I don't know, we'll get to scarring hopefully in a later presentation, but if it's diagnosed as a scarring form, does minoxidil work there? Is it completely ineffective or possibly helpful?
So there's a famous, well-known dermatologist nationally who just gave a presentation recently, and she said, if you're not using minoxidil on all types of hair loss, then you might be missing out. So even though you need to use anti-inflammatory things for scarring hair losses, minoxidil might help turn things around faster. People want to see results. So it's not going to hurt. It just may not be sufficient if you have a scarring hair loss. So you can't just count just on that. That's my opinion.
Okay.
Yeah.
Dr. Young, did you have any thoughts about that to add?
I think Dr. Davis kind of echoes what we think in that, like, it's not hard to do and it's easy to do and it's not going to really hurt patients. So why not?
Okay, very good. Well, there may be other questions that will surface. I certainly have a couple in my hip pocket that I might get to if we have time. But at this time, I'm going to ask that our third-year medical student from the Partnership Campus in Athens, Maya Akbik, if you will share your screen, if you'll begin your case presentation, we would appreciate that.
Perfect. Okay. Can you all see my screen? Fine.
Thank you.
Great. Okay, so I will be giving the presentation on a case. Hopefully you guys will find it interesting. I'm Maya, third-year medical student. Thank you for the introduction. So we have a case of hair loss. Oh, I don't know why it's not. Okay, there we go. Patient history that we saw, a 9-year-old female. She has history of eczema. Her main concern was this hair loss for several weeks, no other symptoms other than that. So on physical exam, we saw this 2 to 3 centimeter patch of hair loss. And on closer exam, you can see that it is not symmetrical. You can see some broken hairs at different lengths, some coiled hairs as well, and also some tulip hairs, which just have a thicker distal end. But the main thing is that you do see some hair within the center. So our differential based on these findings include trichotillomania at the top, alopecia areata, traction, alopecia, telogen effluvium, and tinea capitis. I will be focusing on the top 2 differentials, but first we're going to talk about why it wasn't the others. Trichotillomania is what it came out to be, but it wasn't alopecia areata. At first glance, you'll see that it wasn't smooth, it wasn't round, it wasn't symmetric as a patch, and that's typically seen in alopecia areata. And then at closer exam with trichoscopy, you'd typically see yellow dots or even vellus hairs, which we didn't see in our patient. There is traction alopecia next. We didn't have any kind of history of specific hairstyles that she would use. And typically, as we saw in Sally's presentation, there will be a predictable pattern of hair loss, which isn't consistent with what we saw in physical exam. And on trichoscopy, you'll typically see empty follicles. And then telogen effluvium is typically a diffuse hair loss, and our patient is dealing with more of a focal hair loss patch. And on trichoscopy, telogen effluvium will show upright regrowing hairs, single hair follicular units with perifollicular discoloration, which you don't see in our patient. Tinea capitis typically comes with the symptoms of burning and itching, and the patch itself usually has the scale on top. So we didn't see any of that in this patient either. So those were ruled down. So trichotillomania is an obsessive compulsive spectrum and related disorder. It does go into psychology, and we'll talk about that a bit. There is a dysfunction in a cortical pathway, and it causes anxiety, stress, boredom, or even the tactile sensation of hair to trigger the patient to start pulling on the hair, and the dislodgement of the hair brings a sense of relief to the patient. Typically, a patient will present with recurrent hair pulling that's leading to hair loss, and it's causing clinically significant distress on the patient. Onset is typically childhood or adolescence, and 11 to 15-year-old is the most commonly seen age. Relapses are seen in adulthood, a good amount of it, so that's something to keep in mind. It is more common in females, and it can occur on any area of the body that has hair. So it is most common on the scalp, but it can happen on the eyelids, the eyebrows, anywhere with hair. The diagnosis is based on there being recurrent hair pulling that results in hair loss. There is also repeated attempts to stop and clinically significant distress or impairment that is caused by this. And of course, there's no other medical condition or mental disorder that is causing it. Complications, the main one is psychological, so it includes anxiety and depression and low self-esteem. So that's something to make sure you're following up on when someone has this diagnosis. And then irreversible hair damage is a big issue with this because it's more long-term and something that they have to live with. Trichobezoar is also a huge emergency that can happen and something to keep in mind with your patient just because it can cause gastric obstruction and it can be dangerous, basically. Our patient actually had a description of being anxious by her mother, so that was also something that is seen in trichotillomania a lot of the time based on these psychological complications. Treatment is mostly cognitive behavioral therapy. It has the best evidence supporting it. It includes habit reversal training. But more recent studies have been looking at something called acceptance-enhanced behavioral therapy. It's seeing really good response rates, and it combines habit reversal training as well. You can also do pharmacologic therapy, of course, but it's typically used as an adjunct treatment. Cognitive behavioral therapy is the most supported, it's the most favored, and pharmacological therapy is typically added on just because a patient isn't able to cognitive behavioral therapy is basically not bringing regression. And acetylcysteine and sertraline are the favored pharmacologic agents that are used alongside the therapy. And of course, behavioral therapy with pharmacological treatment optimizes outcomes. So I'm also going to talk a bit about alopecia areata, but I won't repeat what Sally said just to save time. It is an autoimmune disease. We talked about the pathophysiology really well. Clinical presentation, biggest thing was it's typically asymptomatic, so it didn't and smooth and round, and that doesn't match our patient. Typically, cases are in younger individuals, so less than 20 years old, and we went through the different types of alopecia areata you can see. Diagnosis is based on clinical presentation. There is trichoscopy findings that we'll go through, but there is a lot of overlap in the findings with other diseases. Skin biopsy is used for really uncertain cases, and you of course, as Sally said, need to look for other autoimmune conditions. And a lot of patients will see spontaneous recovery within 1 year, so that's really good news as well. Treatment, basically in limited disease, which is the most common presentation, you'll do intralesional corticosteroids. And I saw that the average was about 3 to 6 cycles. So that can take about 6 months at times to see adequate regrowth. And there are other options if someone doesn't want to get an injection, like topical corticosteroids and immunotherapy. More severe disease will typically be followed by a dermatologist. So JAK inhibitors are really favored in that case. And more recent research is really looking into the pathophysiology of alopecia areata even more and why JAK-STAT pathways are so helpful. So that's something we're looking forward to. When it comes to trichoscopy findings, trichotillomania, the main finding that points at trichotillomania is broken hairs being at different lengths. In comparison to alopecia areata, you'll see the broken hairs are about the same length. We also saw coiled hairs and tulip hairs, which points at trichotillomania. And black dots can commonly be seen as well. On the other hand, alopecia areata, again, the broken hairs are the same length. You'll see yellow dots, which you can see in this bottom image on the right. That is pretty specific for alopecia areata, but again, a lot of these findings can be seen in other diseases. And then the vellus hair, which we saw on the alopecia areata slide I had earlier, is that lighter hair that regrows within the middle, and it's a good sign of regression from alopecia areata. And these are my references. Thank you guys for your time. And let me know if you have any questions.
Thank you, Maya. It's very, very interesting. I don't see any questions yet in the chat. We certainly are open to that. So if you would like to drop something in the chat for Maya, that would be great, or raise your hand, or just open your mic and speak out. Give it a second here. Can you talk a little bit about the difference between trichotillomania and other kinds of behavioral related causes of hair loss, or what is sometimes referred to as, I can't remember, but it's like mimicking behaviors or whatever that include not just hair pulling, but rubbing or rubbing the scalp aggressively, or even tapping and patting the scalp aggressively. You have any information to share on that?
My main findings were about trichotillomania. I haven't read any specific dermatology findings of the rubbing or the tapping exactly, so I can't speak best on that. I don't know if others know better than me.
Dr. Davis, let's see, Dr. Rabinovitz, any thoughts about that?
We do see people who get lichen simplex chronicus of their scalp where they just kind of keep rubbing a spot. And then you'll see the hair breakage too, but then the skin actually gets red and a little thickened under there. So especially if people are a little atopic, they can kind of really find a favorite spot and go after it. So I will say that we'll see lichen simplex chronicus.
Yeah.
So if you rub the skin, it becomes thicker. That's lichen simplex chronicus. If you pick, you'll get what are called Picker's nodules. And these are two different types of conditions which are characterized. They're inflammatory disorders, and we're getting some headway, at least, with some of the new medications to treat these disorders. And those are the only two other aspects that I could think of. And we do certainly see patients who do pick their skin.
Yeah. Okay. All right.
Yeah, I think an interesting point about trichotillomania is that It rarely affects the occipital scalp because it hurts a lot to pull along the occipital scalp. So most of the time people leave that alone because that hurts too much. And it's, as Maya said, it's usually young females that we see this in. And occasionally you can see it in little folks, 1.5, 2-year-olds who just kind of yank at their hair and then eat it. And so trichobezoars can happen in very young individuals, and that's not felt to be any kind of mental illness or something. That's just kind of, I don't know what babies sometimes do. I don't know that I've ever seen that, but people talk about it.
If they get it in their hands, it goes in their mouth. That's
Everything goes in their mouth, right?
good. All right. Any other questions for Maya or maybe for Dr. Young? I have to ask this question because I'm getting a little tired of seeing the commercials. Can someone tell us whether Nutrafol is worth anything or not? Anyone? Maya, give us a shot.
I'm sure the study.
Hey, oh,
Oh, sorry. Go ahead.
So go ahead.
no, I was
didn't-
just gonna say, sorry, I have this terrible cough, so if I go into a spasm, I apologize. But yeah, I had a patient ask me this today, and I mean, I think the one main thing is that it's very, very costly. We looked it up today. It's $88 per bottle. And I don't think there's just enough data behind it to suggest that it's going to be anything comparable to minoxidil, or things that we already have that are significantly less expensive, especially if the patients are, eating an adequate diet and, you know, getting their nutrients and vitamins from other sources.
Okay.
Yeah. I'll add that I think biotin's in there, and biotin it's all the rage now too. And you really don't want to take too much biotin. So 2,500 milligrams is what people will recommend to make like nails thicker, and because it's been shown in horses to make their hoofs stronger. So that then followed that people studied it in nails of humans, and they've shown it makes it a little thicker, and then people think it maybe helps each scalp hair be a little thicker. So there's a little science there, but if you take too much, then it kind of is not a good thing. So that's one thing that there is maybe a little science, but you don't need to take 10,000 units, which is, what people find, they overdo it. And then finally, if you do take biotin, you better not do any don't want to have labs done the 3 days before, because it'll mess up your thyroid function. It'll mess up testosterone and estrogen levels, and it messes up troponins too.
Oh,
And
wow.
so if people are taking biotin, that's just a little pearl. They need to not take it the 3 days before they have their labs drawn, especially thyroid. That's a big deal. So anyway, I'll share that with you because everyone's doing, as you said, all these supplements.
That's great. So there's a comment and a question from Yi Swan Ku, who's asked, says that a patient with androgenic alopecia who's hesitant to start minoxidil due to concerns that you could have a withdrawal effect if you stop it. Is there any evidence to suggest that discontinuing minoxidil worsens hair loss beyond the baseline progression?
I can answer that. I mean, so if you take minoxidil and you grow hair and you stop it, you will lose all the hair that you would have lost up until that point. It'll shed. So if it's holding on to 10% of your hair, yeah, you will shed that, but then you can always restart it, and because that hair follicle is still there, it'll grow. But you're not going to lose any more than you would have lost had you never taken it.
Okay, good.
Good question.
We have another good question. Are there other options besides minoxidil for patients who develop a scalp sensitivity or irritation? I guess maybe switching to oral. I don't know.
That's when a lot of people switch to oral, which, it made me nervous because I was around when they started using oral minoxidil for blood pressure, and whew, this is a really strong drug. But more and more that this baby dose is felt to be extremely safe, and everyone's doing it baby dose. So I always tell people to try topical, and then if they just won't do it, can't do it, then, oral is a lot easier for some people just because they don't like that drying effect that minoxidil can give you.
Okay, I can't believe no one has put anything in the chat yet or raised their hand to ask the question about low-level laser near infrared light to treat hair loss. I've seen,
There,
hundreds of dollars for caps to go on their head, so.
there is a comment in the chat about the Nutrafol from Dr. Maynor. I actually have Nutrafol, no biotin. There's vitamin A, C, D, K2, B12, iodine, zinc, and selenium.
Okay, it's a good mix.
I just don't know that since it's over the counter, it's really been studied well. I think that's the whole thing, and it's expensive. I think the red caps, I mean, there probably is some evidence for red light to be anti-inflammatory and be helpful, but it's super expensive. But there is, I don't know, maybe someone else can chime in, Kendall or Dr. Rabinowitz, but I think there is some evidence for that. But it's not going to work as well. I mean, I think you should always use minoxidil first. It's going to be a lot cheaper.
All right, any further comments?
Yeah, I agree. I mean, red light therapy is all the rage right now, which is great, but there's like so many devices out there. And so I think it's just hard to know, especially for patients to choose the right device at a cost that's reasonable and also sort of know how to manage the settings and all that. So I think still more to come from the red light angle.
I'm always a little concerned when there's an identified spectrum of light that is thought to be the effective area. And so someone sells you something that looks red like everybody else, but it may not be technologically refined to offer the therapeutically effective range. Because most of us don't have a way to measure that sort of thing. So that's always an area of concern for me with things like that. All right, well, this has been great. It's been fun. We've just got the continuing education codes popped into the chat there. I want to thank you, Maya, for your presentation and for your engagement, and also Dr. Young for yours. And I always appreciate Dr. Buchanan, Dr. Rabinowitz, and Dr. Davis chiming in to give us some wisdom to go along with the information. So with that, I'm going to turn it back to you, Dr. Markowitz.
Okay, well, thank you, everyone. Dr. Young and Maya for great presentations and for the good discussion. Certainly a timely and popular topic, I think. So let's see if we can have the last slide. Okay, so the CME code is here towards the bottom of that slide. Remember, for any newcomers, that you have to be registered with MCG's CME department in order to text in the code. And if you have any questions about that, you can contact us at teledermatology at augusta.edu or Kenza. And she can help with that. Our next session will be March 2nd. That's the first Monday of the month. And our topic will be patch testing and will be presented by Dr. Chris Riley. And I want to remind people that we are very, very happy to have any of you do case presentations. We obviously have some medical students who do them, but those of you in the in your clinics, if you have a case that has an interesting presentation or you're not sure of did you do the right thing? Do you want more advice about a particular patient? Anything that's interesting, please feel free to contact us to do one of our case presentations. You don't have to, there's not a lot of work involved other than giving the history of the patient and showing some slides and what you thought the outcomes were, or so forth. So we're really happy. That's the whole point of TeleECHO, is to have this horizontal learning from one to another. So please let us know. And with that, I think we can end today's session. If you didn't sign in, please very quickly sign in with your name and email address. And other than that, I think it's our guests can sign off, and I just ask the members of the TeleECHO Hub to stay on just for a few more minutes to discuss things. So thank you very much, and hope our weather warms up. And it was nice having the snow, but it'd be nice to not see it again for a while. So have a good week.